Thank you all for coming to the Memory and Aging Project Participants Meeting. It's always a highlight of our year to be able to share what's gone on in Alzheimer research in the past year with all of you, because you, of course, are the reason that we have a research program because of all of your contributions. So I do want to indicate that it's time, if you haven't done so already, to take your electronic devices and put them on silence mode or turn them off. The necessary rooms, I think, are out the door and to the left. And you can feel free throughout the program to get up and refresh your coffee or water or whatever you like. So I may have a little bit of bias, but I think our Knight Alzheimer Disease Research Center is the best such center in the world. And that's because of two major factors. The first is all of you, our participants. You are the most dedicated, committed, supportive, interested, active group of participants in any program. So give yourself a huge round of applause. And the second reason is, for some ways, I'm not quite certain how it's happened, but we have the best faculty and staff of any Alzheimer's disease center in the world. So I would like all of our faculty and staff to come forward. They're seated around the back, but come forward, stand up. If you're at a table, stand up. Come on, everyone up, and move this way. Move this way so people can see you. All over, stand up. Let's give them a huge round of applause. Now, to organize this meeting, everyone in the Memory and Aging Project staff worked very hard to do that, but of course there are always people who have to take the responsibility, and I'd like to thank in particular three individuals. First, the audiovisual needs here are not trivial, and in the back in a blue shirt is Ron Hawley, and he masters everything. So give Ron a big round of applause. And then we have different components of the Alzheimer's Center, and the outreach outreach core is the core responsible for this, and it is led by Andre Denny, who is in the gray jacket in the back. And the person who does all of the work is Andre's colleague, Jennifer Phillips, and she's in the black dress in the back. All right, let's begin the program. So I've explained this, but it bears repeating, I think, because it's a little bit complicated. Our Memory and Aging Project is the office where you come once a year to have your annual evaluations, your clinical and memory testing done. It was established by my predecessor, my mentor, a man named Leonard Berg, now deceased, in 1979, even before I arrived at Washington University. I came here in 1982, and the Memory and Aging Project was set up to understand how memory and thinking should develop as people got older, aging, normal aging, and how it differed, and how people who had Alzheimer's dementia differed in their memory and thinking over time. So comparing healthy aging with Alzheimer's dementia. Now, we support all of our research, almost all of our research, through federal grants. Grants from the National Institutes of Health, and particularly the National Institute on Aging. These grants are competitive. We must apply for funding. We must justify in our application why we deserve to have the grants, and a panel of our peers reviews it and determines whether we merit that grant award or not. The grants are awarded for a period of 5 years, and so every 5 years we have to reapply, justify why we think we deserve to be supported for the next 5-year cycle. We have many, many of these grants. We have, as I said, the best team of faculty and staff in the world, so they are very competitive and receive many awards. But we have 3 major grants that support the Memory and Aging Project and the Alzheimer Center. The first is a grant called the Alzheimer Disease Research Center Grant. Dr. Berg, my mentor, got the first award for that grant in 1985, and subsequently every 5 years we've been successfully renewed. A family in town, Charles F. and Joanne Knight, in 2010 gave a gift that endowed the ADRC, so we call it the Knight ADRC. And we're not the only Alzheimer center in the United States. Right now there are 37 such centers funded by the National Institute on Aging. We have 2 other major grants. One is called Healthy Aging and Senile Dementia. Those are archaic terms. We don't say senile dementia anymore, but that harkens back to that original Memory and Aging Project in 1979 when people thought that Alzheimer's disease, they didn't use that term. They called it senility. And that goes back to that original study. And then the adult children study, which both of those program project grants, the original Healthy Aging and Senile Dementia started in 1984, and the adult children study in 2005. But for you, it doesn't matter which grant is supporting the assessments that you go through. You come to the Memory and Aging Project, and that's all that is necessary because all of these grants support the Memory and Aging Project. Now, it turns out in this grant renewal cycle, it's our year to reapply to the National Institute on Aging for another 5 years of funding for our Alzheimer's Disease Research Grant. And we just submitted it last week, June the 6th, for funding for years 41 through 45. If we're awarded the grant, and we will be, it will start next May 1st. The total amount of funding that we're asking for is $22 million over 5 years. The justification, our application, was 937 pages. In preparing the grant, we looked at why we deserve to get another 5 years of funding for $22 million. Well, you can see that investigators around the world, not just our investigators, but investigators around the world ask for access to you, the participants, and or the data that are generated with you about your cognitive memory abilities and so forth, as well as the images and the blood samples and the spinal fluid samples. We had 236 requests for access to your information so it would help their studies. We provided them with what they requested, and they then used that to apply for their own grants. And you can see that in the past 5 years, their grants totaled about $130 million. That's 6 times more than the $22 million that we're asking for. So we keep building forward, building on what we're doing. And of course, we contributed to the scientific literature with over 500 scientific publications in the past 5 years. So very productive, and again, goes back to you, the participants, and our faculty and staff. This is our leadership. We are organized around cores which support our scientific projects. The administration core has been led for the past 25 years by myself, but last July, as I told you at this meeting, I transitioned that to my colleague, David Holtzman, who unfortunately can't be here today, but I am no longer the Knight Alzheimer's Disease Research Center Director. I'm now the Associate Director or Co-Director or Emeritus, I'm something. But it probably doesn't matter whether Dave Holtzman or myself actually serves as the director, because we have an executive director, Krista Mulder. Where is Krista? Okay, Krista Mulder way over there. She's got her hand up. She is the best executive director of all 37 ADRCs. The clinical core, that's the Memory and Aging Project where you come for your assessments. I'm still the leader of that, assisted ably by Nicole Elmore and a fabulous staff. I'll introduce them in a slide in just a bit. Of course, all the data that we generate have to be analyzed. Kenji Zong leads our biostatistics core. We ask for brain donations only after you're finished using the brains. For people who have been in our study and pass away, and our neuropathology core is led by Dr. Rick Perrin. We ask for blood so we can analyze the genetic makeup of all of our participants, look at the DNA, and that's Carlos Cruchaga. The testing, the memory testing, is led by Jason Hassenstab, the imaging by Tammy Benzinger, the fluid biomarker core led by Suzanne Schindler, who is up on the podium, and you're going to be hearing from her. I've already mentioned the outreach, recruitment, and education core led by Andre Denny. The biomarker core takes your skin biopsy. Some of you have had skin biopsies, and those skin cells are grown into additional cells that can be used for study, and that's led by Celeste Karch. And Celeste is here somewhere. Where is there? She's raising. She's standing up, actually. Stand up, Celeste. Our clinical trials unit, where we test new agents to see if they're effective to treat Alzheimer's disease, experimental agents, led by Joy Snyder. Our health disparities and equity core, led by Joy Ballsberry. And Joy is here. Where is Joy? She's standing up too. She's over there. Yep. And our research education component, led by Joy Snyder and Susie Stark. This is training the next generation of Alzheimer investigators. So it's a fabulous group. I do want to point out that there are, in the leadership role, more women than men, so that's another reason we're the top ADRC. And here is the organizational chart for the Memory and Aging Project. Once again, where you come to get your evaluation. So we have nurse coordinators, we have fabulous nurse team, we have fabulous social workers, we have research coordinators, we have clinicians, both physician clinicians and advanced practice clinicians, and we have the cognitive assessment team. I'm going to show you that we're continually trying to improve and increase our capacity to see all of you and to add new participants to our roster. And the people highlighted in yellow are new since the last year. So Anna Middleton, is Anna here? Yep, Anna's standing up too. Welcome, Anna. Jessica Wold, is Jessica here? Oh, stay standing up. She's over there. Courtney Kovech is here. She's a nurse practitioner. 3 physicians. Last year I introduced Michelle Rudman. I don't know if Michelle is, yep, Michelle is, you were in the same place last year. She's a neurologist, and she's been with us for this past year. And then 2 new testers, cognitive testers. So I have to tell you that I sound like I'm getting a little forgetful because I'm repeating myself, but we do have the best faculty and staff. the pandemic shut down all research assessments for a long period of time. The National Institute on Aging doesn't care so much about that. They said, well, we gave you $22 million to see 150 new participants. Why aren't you doing that? Well, we couldn't. We were shut down. So when we finally opened back up, all of this team worked doubly hard to do extra assessments so we could bring people in, and we exceeded our recruitment goal because of the hard work of this remarkable team. And another facet of this that I hadn't truly appreciated, but my thanks to all of you, because when we asked our new participants, what got you interested in joining the Memory and Aging Project, by far and away the number one answer was, well, I talked to somebody who was in it. You are our best recruiters. And I'm absolutely certain that people who know you would say, well, why? If they had a good experience, then I trust them, and I'll sign up also. So keep it up. We need more new participants. So thank you for your recruitment efforts. Here are our two new clinicians, faculty clinicians, who will begin in July, both neurologists, Jonathan Williams and Maren Gregerson. So I show them because they can't be here today, but you'll see them beginning in July. So we have many research projects addressing many questions related to aging and Alzheimer's disease and other dementias. But overall, what we're trying to do is identify Alzheimer's disease when it begins. And it begins many years before it causes dementia. Dementia is the loss of memory and thinking that begins very gradually, but ultimately impairs a person from being able to do what they're accustomed to doing. Well, the brain harbors Alzheimer changes, as I say, for years before it causes enough brain damage to produce dementia. So we want to identify this long asymptomatic, we call it preclinical stage of Alzheimer's disease, and we do so by all these sophisticated imaging techniques and analysis of fluids, blood, spinal fluid, to identify in people who have no problem with memory and thinking, it's starting in the brain. We want to do this because we want to know if it starts in the brain, does that mean for that person that inevitably, if they live long enough, will they develop Alzheimer's dementia? We don't know the answer to that. Maybe some people can begin to have the changes of Alzheimer's in the brain, but they don't progress to developing dementia. That's what we're trying to answer. We're trying to understand what changes to make the brain tolerate these early changes without dementia. Why does the brain eventually fail and dementia is expressed? And most importantly, we want to identify this early stage, asymptomatic stage of Alzheimer's, because we want to start introducing medications that hopefully would delay the onset of dementia ever appearing, or even preventing the dementia. We think prevention is much better than treating once the dementia has occurred. We also understand that there are differences in people, and we must study as many people from different walks of life as possible to know if what we're learning is applicable to everyone. If we only study one group of individuals, we'll only learn about Alzheimer's disease in that group of individuals. So we want to examine whether there are differences across different particular groups of individuals. So on the left here, we're looking top down on the brain. The brain is all of this folded material. These are made up of different cells, and I'll show you that in just a moment, and divided into two areas, a left part of the brain and a right part of the brain. And this side is looking from the brain from the left side, and we see the front of the brain and the back of the brain. Now, all of these regions have different functions. The back part of the brain, for example, called the occipital lobe, receives the images our eyes receive and interprets them into what those images represent. This left side of the brain here and over here are responsible for language. This front part of the brain is responsible for judgment. Deep inside the brain are memory regions. So this is what the brain looks like as a whole. But the brain is made up literally of billions of cells, so small you can't see them even with except a high-powered microscope. So this is a diagram of a brain cell. It's called a nerve cell or a neuron. This is the cell body. It has a nucleus, and it has many extensions. These extensions communicate with other nerve cells. Some of these extensions receive signals from other cells, some provide signals to other cells. That's how brain cells communicate one with the other. Under normal circumstances, the brain is supported by many other cells. The nerve cells are supported by many other cells that keep these nerve cells happy. And there are many things floating around in the brain substance. One of them is a protein called amyloid that normally is in solution. It's in the fluids of the brain. For some reason in Alzheimer's disease, this amyloid protein comes out of solution, becomes solid, and is deposited in the brain tissue. And this represents amyloid proteins forming what we call an amyloid plaque. Now these supporting cells, so this is the brain neuron, this is billions of neurons in the brain, that's how we think, act, move. Here's an amyloid plaque not supposed to be there. Amyloid isn't supposed to come out of solution, be solid, it's supposed to be in the fluid. So these other brain cells say, this is abnormal, let's attack it. The microglia, the astrocytes, other inflammatory processes, they attack this plaque, trying to get rid of it. The problem is, the way they attack it also isn't limited just to the plaque, but gets into the rest of the brain substance and affects the brain neuron. So the neuron, the nerve cell, is an innocent bystander, but it gets damaged. And the damage is represented by something called the tangle, neurofibrillary tangle. This represents an injured nerve cell. This tangle is made up of another protein called tau. And when you see tangles in a neuron, it means it's injured and possibly on its way to cell death. That's what happens in Alzheimer's disease. Nerve cells die. And they do so because this amyloid plaque is abnormal, should not be there, and the neuron or bystanders get injured by the process trying to remove the plaque. So this is the way we think of Alzheimer's disease. The symptomatic phase here is the dementia phase. It begins very mild, hard to tell when people are really on the way to losing their memory and thinking, but it progresses inevitably, always gets worse, and results in death, often after a course of some 7 to 10 years. But there's this earlier phase, we call it the preclinical phase, where the Alzheimer process is beginning, and we can detect it with our amyloid imaging and our spinal fluid analyses, but there is no brain damage. The brain cells at this stage stay intact. And that's why memory is intact. There is no dementia. But as this preclinical phase continues to build up, it will affect the integrity of those nerve cells, and when they start to fail, that's when the dementia begins. So we would like to identify that preclinical stage introduce medications to prolong it and prevent the dementia phase. How do we do that? Well, all of you come in annually for your assessments of your health and your memory and your thinking abilities. We get your blood every 2 years and we analyze it. We get MRI scans and PET scans every 3 years. And we do spinal taps or lumbar punctures to get your spinal fluid every 3 years. I've said this before, but just to reiterate, although the spinal tap takes place in the low back and we call it spinal fluid, it's generated in the brain. And so having an analysis gives us an insight into the brain health. So this is what we do. You are, as I said, the most committed, most dedicated group of Alzheimer participants anywhere, and you do a great job. But I do want to tell you that a single spinal tap or a single amyloid PET scan, although very helpful, doesn't tell the whole story. So let's take a look at this. Let's say that this is somebody's value of their spinal fluid proteins. Here there's a man in blue and a woman in orange or yellow. And let's say that the normal value for those proteins is right here at 0. Let's also say that if you are going up on this scale, that means you have less and less and less of this value, less and less of the Alzheimer proteins. If you're going down on this scale, it means you have more Alzheimer proteins. You may be on the way to Alzheimer's disease. So looking at this man had his spinal tap and it looks like he's pretty healthy. This woman had her spinal tap and the proteins are on the way to getting Alzheimer's. But that's not the whole story, because look what happened. Over time, the man went down, and although the woman didn't get better, she didn't worsen. Does that make sense? And actually, the story goes even before that. The man started out really healthy, and I showed you this time, but he already is on the path to Alzheimer's. Does that make sense? And the woman never changed. So it's assessing your images, your blood, your spinal fluid over time that tells the story, not just a single one. Am I making sense? You do a great job. 80% of you complete everything we ask of you, the PET scans, the brain scans, 77% lumbar puncture. And now I can tell, after I've just presented all this, that you are going to go home and enthusiastically call our Memory and Aging Project on Monday and say, give me my second spinal tap, right? Or my third or my fourth. So Nicole, let's get the lines open on Monday because they're going to be calling in. We ask a lot of you. We know that. We know that. These are all the things that we ask of people in the Memory and Aging Project. I've been over most of them, but I've already mentioned you are recognized as being such a valuable group of individuals that other investigators, not in our Alzheimer's Center, want access to you and your data as well, extra studies. And so we vet those requests for access to you, and we try very hard to adjudicate burden. We don't want to, we know we burden you already. We don't want to overburden you. But we do support certain studies, many other imaging studies. Some of you are in the driving study, fall study. Can air pollution cause Alzheimer's disease? Can looking at the eye, the retina in the eye, tell us about Alzheimer's? And one of our coordinators, Cody Holt, some of you may recognize that name, may look over your particular profile and say, well, I think Mr. X could be a candidate for the drive study. Let me call and see if he's even interested in it. And he'll call you and say, here's the study. If you're interested, let me know. And then Cody can give, if you are interested, the name to the drive study personnel, and they can call you and you decide whether to participate. So I think it's important to know from you why you participate in our research, and two of the participants here today have agreed to let you know why they are a participant.
I got an opportunity to meet Dr. Morris on my last visit into the office, and I want to thank him and all the participants for providing an opportunity for me to help future generations. One of the things that's most important to me is that we are here for a season, and we gain quite a bit of knowledge and we gain experience, and it is important to us to pass that on so that future generations don't have to relearn those lessons. And this opportunity to help science, which is a very difficult discipline, things that they learn, after years they can find out that they were headed down the wrong path, and so they require our participation to make sure that they are providing the best resources for our future generations. And I want to thank everyone for listening to me this morning.
I got into this study, read a newspaper article that they were recruiting for something called the Adult Children Study back in 2004. Since my father had Alzheimer's and was part of the Memory and Aging Project, I volunteered. And as a result, I've been through 7 LPs, number 8's coming up next year. More MRIs and PET scans than I can count. I've done 15 years, and they gave me a pin for this one, of psychometric testing. Now, some people torture testing, but I don't. I've basically been in the fall, sleep, driving, smartphone, gut, and exercise. And I have a pile of informed consent documents. There's more than 3 inches tall. Okay. When I began this study, I really didn't like scanners. I made them put a cloth over my eye before they put me in a scanner. Well, they eventually worked me up to a...
Bill, hold it real close to your mouth so people...
They eventually worked me up to a 4-hour scan. And then I was not enough to do it once. They came back for a second. Okay, for 20 years that I've been in it, I haven't had a problem in any of the studies. You know, no problems with the MRIs. I overcame my fear of scanners. So there's just no reason not to be here. I met and got to know a lot of talented people, very dedicated, all knowledgeable, and all very helpful. And I learned a lot about Alzheimer's disease. I also made some friends along the way. Jessica. Basically, my time with the ADRC has been very personally fulfilling. I'm very proud that I could make a contribution to the work of the ADRC. I want to thank Dr. Morris and the ADRC for working to further the understanding and hopefully soon the cure of this dreadful disease. I encourage all of you to continue support of the ADRC in this task. Thank you.
Thank you. Thank you both very much for those comments. We do reimburse people for participating, not a lot, but you can see here what we reimburse for having a brain MRI scan or a PET scan or a spinal tap or lumbar puncture, LP, different studies. Just last month, May 24th, we decided also to start reimbursing you for your time when you come in for your clinical assessment and your cognitive testing. Unfortunately, Bill DuBois, this means we have to get another consent form because this payment reimbursement wasn't in our original one, so we have to reconsent everybody. But anyway, so we do appreciate that you give us much of yourselves, including your time, and we want to compensate you for that. You all told us that you want to get your research results. So Sarah Hartz, who is here, and Jessica Mazurski is here, started got funding from the National Institute on Aging grant to start sharing your research results with you if you want. Now, it turns out that not everyone wants to know their research results. Is their amyloid PET scan positive? Do you have amyloid in the brain? About 62% of you turn out to say yes, but 38% say no. And so far, Dr. Hartz and Dr. Mazursky have been returning results to people, including the amyloid PET scan results. No one has said, I'm sorry I decided to receive it, but 3 out of 102 were upset when they learned the results, although with time that ameliorated. All of you who have had your results returned to you have said, I appreciate the care in which you provide them, and we're going to follow this along, and we're going to expand. We're going to return research results to all participants who want. We started out, Dr. Hartz and Dr. Mazursky started out just with our people who don't have Alzheimer's dementia, but we're going to now expand this and provide research results to anybody who would like to learn them. We also, about a year ago, started getting another vial of blood to look for vascular risk factors, your cholesterol level, your risk for diabetes, and so forth. And we are giving you those results as well. Not here in this room, but 826 participants are in the Knight ADRC. They range in age from 40 to 100. 17% identify as Black or African American. Look at this. Your average education, years of education, is that of a college graduate. People come from all over, including California, New Hampshire, and the longest terms of participation, 37 years. We have a fabulous African American advisory board. It began in the year 2000, and the inaugural chair was a civil rights activist and educator in St. Louis, Mr. Norman Say, who passed in 2019. We have an annual lecture in Mr. Say's honor and now memory. And last October, we had Angela Hill from the University of South Florida College of Pharmacy come to speak on avoid excluding marginalized groups in a new era of treating Alzheimer's disease. I mentioned we have a clinical trials unit where we and other programs test new drugs, experimental drugs. The people who participate in those trials of these new drugs are almost all upper middle class whites. So if the drugs work and get rolled out, approved by the Food and Drug Administration, we are going to be giving them to people who weren't in those trials. And we don't know whether the drugs work the same or have the same risk profile because the trials weren't representative of the general population. That's what Dr. Hill presented on this past October. We also followed the Say lecture this past October with a national conference on enhancing participation by minoritized groups in Alzheimer's research. All 37 Alzheimer's disease research centers had representatives in the audience. We got funding through the Alzheimer's Association and the National Institute of Health. You can see that of the audience, almost a third identified as Black or African American, but also we had some Native American Indians and some Hispanics that aren't shown here. We also see one of our African American Advisory Board members at the podium there, and that's Beverly Foster, and Beverly is right over here. Wave, yeah. This is what we learned from the conference. We must have our research in all groups of people, to learn about Alzheimer's disease and related disorders in all groups of people. To do that, we have to be certain that the groups that we approach find that we are genuine. We have to give them something before we ask them something. It's going to take time to build relationships. And many people don't want to come to our medical center, so we plan to be going out to the community. And we are trying, as always, to have a diverse research team. We are very fortunate at the Knight ADRC to have many partners that support us in our research, including the Greater Missouri chapter of the Alzheimer Association. I mentioned at the beginning, you probably forgot, it's been so long ago, that we had the Memory and Aging Project start in 1979, before I got here, by Leonard Berg. The families of the demented people, remember they called it senile dementia, had no idea what they were expected. So they formed a small group to talk to one another, the family members of those individuals. That started the St. Louis chapter of the Alzheimer Association, that research group. We have an ethics committee. Mr. Du Bois is on the ethics committee. Links, St. Louis chapter, a very important group of African American women. Our Center for Aging at Washington University, our Hope Center at Washington University, our teaching hospital, Barnes Jewish Hospital, institutional support, and many, many donors, some of them exceptionally generous donors. I talked about having more representative research participants. It's said that certain groups, particularly Black or African American and Hispanics, are at more risk of developing Alzheimer's disease than white. That may not be biologic or genetic. That may have to do with social factors. For example, turns out that the better the education we have and the more years of education we have, the less risk of Alzheimer's we get. So I just would say that I think if you had the good fortune to attend a school system in the Parkway School District versus another school district that doesn't have those resources, you may have some protection, whereas the individuals who didn't have that access to that high quality school system may be at great risk. Some of you who know people with dementia, or if you have yourself very mild dementia, our clinical trials unit is starting a new trial of a new agent. It's called CT1812, a drug that does affect amyloid. The advantage of this drug is it's a pill. So here are the qualifications to get into this study. The age 50 to 85, very mild early Alzheimer's disease. And is Sonia here? Yep, right in the back. Sonia is standing up. She is the coordinator for the clinical trials unit. If anyone thinks you have a referral, I'm sure she'll be happy to take it after the program. Basically, there are two treatments for Alzheimer's disease. One are drugs that try to improve or at least prevent the progression of the disease, the symptoms of the disease, but they have nothing to do with attacking the underlying causes of Alzheimer's. You know these drugs, Aricept, now called donepezil, and Namenda or memantine. But there's a new class of drugs. Actually, not so new. We've been testing them since 1999. But drugs that attack the very pathology of Alzheimer's, amyloid, tau. Those are called disease-modifying therapies for Alzheimer's. And we have one. We have a disease-modifying therapy that was approved by the Food and Drug Administration last year. It's called lecanemab, or Leqembi, and we are giving it to our memory patients in our clinic. There's another drug that we expect to be approved by the Food and Drug Administration very soon because the FDA's advisory committee gave it a unanimous approval just this past Monday. These are drugs that target amyloid beta and effectively remove amyloid from the brain. I don't care what drug you take, including aspirin, all drugs potentially have side effects. And these disease-modifying therapies have two side effects. One is they have to be given by infusion, intravenously. And people who get infusions can have side effects. And the second is related to these particular drugs that remove amyloid from the brain. They can cause edema or even bleeding in the brain. The term for this is amyloid-related imaging abnormalities, or ARIA. About 20% of people who get an anti-amyloid therapy for Alzheimer's will get ARIA. This is what it looks like. This is the edema, this white in an MRI of a brain of somebody who got the drug. This is the edema. And the hemorrhages are little dots. Do you see these little black areas? Those are, on the brain MRI, actually areas of bleeding into the brain. So it can happen. We detect it by getting brain MRIs every few weeks in people on these drugs. This is a new era for us. We've never had a drug that treats the pathology of Alzheimer's disease. I've already said that the information from the studies of these drugs were almost all in upper middle class white people. We don't know whether the general population is going to benefit in the same way or have the same risks. We don't know how long to treat. The trials only went for 1.5 years. Do we keep treating after 1.5 years? These drugs are very costly, over $25,000 just for the drug for a year. Plus you got to get amyloid PET scan. We don't give the drug to people who don't have amyloid in the brain. Doesn't make sense, right? These drugs get rid of amyloid. If you don't have amyloid in the brain, why expose you to the risk? So you have to have an amyloid PET scan or blood or CSF testing. I've already mentioned you have to have multiple MRIs to look at the side effects. Then the infusions cost money. Plus, we have very limited capacity. There aren't enough dementia experts in the United States to diagnose everyone, to make sure that they're eligible or ineligible for there aren't enough infusion centers. And then all of this monitoring, who's going to pay for all of this? Madeline Paczynski is at the end of this table, and she's going to talk about this because she's intimately involved with our treatment with this new drug, Leqembi, and she'll give you more information about our experience. I think these drugs that are available now are just building blocks. Over the years, we'll get more effective drugs. We'll start combination therapies. Why give a drug that attacks only one part of the pathology of Alzheimer's disease, attacks amyloid? Let's get drugs that attack the tau tangles and the inflammation. And I've mentioned several times, I think prevention before the dementia may be the best way to prevent Alzheimer's pathology. Here's our lineup of speakers. Madeline's going to talk about our experience with this new disease-modifying therapy. Dr. Suzanne Schindler is going to talk about blood and biomarkers in Alzheimer's disease. Dr. Cyrus Raji from our imaging group is going to talk about obesity and Alzheimer's risk. And Araya Asfal is our postdoctoral fellow, going to talk about caregiving challenges. Now, I'm going to end because I think I've mentioned at all of the programs that eventually I am going to fully retire, and I'm looking for people to take over my positions, and I've identified 4. My two grandsons, Jack and Thomas, and my 2 granddaughters, Molly and Grace. Thank you very much. You know, at the end, we're going to have question and answer on your table, our cards and pens. You fill out your card, and at the end of the presentations, we'll collect them and we'll have a question and answer period. So hold your questions for now, and please welcome Madeline Paczynski.
Alrighty, and
She's a little nervous.
oh, just a little. And so I have the task of presenting from clinical research to clinical practice, disease-modifying therapies for Alzheimer's disease, our experience in our memory diagnostic center within our anti-amyloid immunotherapy clinic. And so I have 5 minutes, so I will try to speak slow enough so you can hear me. And so our lecanemab LEQEMBI experience so far, as of Sunday, we have 183 patients who have received at least 1 infusion. We have 88 who have received at least 10. 28 of our patients have experienced some form of amyloid-related imaging abnormalities, and 5 of our patients have had to discontinue infusions due to ARIA. And then, on the other hand, 69 patients have reported infusion-related reactions. And so our experience with ARIA in the real world, so 28 out of 183 patients, that is about 15% of our patients have experienced ARIA. And so symptoms of ARIA, they can be very vague and nonspecific, and they exist on like a spectrum of severity. So waking up a little dizzy to full focal neurologic deficits, seizures, even stroke-like symptoms. And so in between that, there's headaches, vision problems, nausea, difficulty walking, confusion. And so these can be particularly hard to assess in this population. And so how do we monitor for this in the clinic? Similar to what we did in the trials. And so every patient is required to have a baseline MRI with proper sequencing that can detect these things, and then they're also required to have regularly scheduled MRIs before their 5th, 7th, and 14th infusion. And then if they are to be symptomatic at any point, they are required to have more of an urgent MRI. And so then ARIA is graded on 2 scales, and that's radiographic severity and also clinical severity. So radiographic severity is determined by our neuroradiologists and so what is seen on the scans, and then clinical severity is how patients, so if they're symptomatic, and if they're symptomatic, how severe and how debilitating the symptoms are, and how they present clinically if they have changes on their clinical assessment or neurologic exam. And so then ARIA is managed dependent on where they fall on these scales. And so long story short, all mild asymptomatic cases are able to continue infusions if they wish to, but every other ARIA scenario has their own trajectory. And so, all but one of our ARIA cases have been found on those pre-scheduled surveillance MRIs. None has been found on any urgent MRIs, or one has, sorry. And so infusion-related reactions, I won't rattle off all the symptoms because I will sound like a drug commercial, but very broad and vague symptoms. And on the more severe end can be life-threatening, breathing difficulties, and even anaphylaxis. And so these aren't specific for anti-amyloid therapies. They're actually quite common in many immunotherapies. And they're usually mild. We've had no severe cases, and there were no severe cases in the trials either. And they typically resolve after the first couple infusions. And so in our experience, pre-medicating and slowing the rate of infusion can help, but some patients continue to experience discomfort with subsequent infusions despite these efforts, and 4 of our patients have actually had to discontinue infusions because of infusion-related reactions. And so in the trials, this occurred in 24.5% of participants, but in our experience, we're seeing a little more of this with 38% of treated patients reporting infusion-related reactions. And so this Venn diagram kind of represents a problem that we face a lot in the clinic, and that's because of those very broad, non-specific symptoms that occur in both symptomatic ARIA and infusion-related reactions. And so again, symptomatic ARIA is quite rare, with only 3.8% of our participants experiencing some degree of symptoms. And while infusion-related reactions, as you saw, have occurred in 38% of our patients. And so as you can imagine, when you just tell patients and families that they're starting a therapy with the potential to cause brain swelling and brain bleeds, any changes in how they're feeling can cause some anxiety and will scare them. And so this scared us too, and it continues to scare us sometimes, and we always err on the side of caution. And so in the beginning of this journey, we were ordering MRIs in a lot of patients who had infusion-related reactions because we were worried that they were having ARIA. And to my knowledge, not a single one of these MRIs showed any ARIA, and so that was reassuring. And so how do we know it's not ARIA? So timing tells us a lot. So infusion-related reactions occur within hours of treatment, and with our experience with lecanemab, it's actually a couple hours afterwards, and sometimes even in the middle of the night after their first infusion. And ARIA does not typically present that soon into treatment. So that's one way, but there is a lot of ambiguous cases. And so another topic, so what's the holdup? Why this was approved about a year ago, and why is this not widely available? And there's so many reasons for this. Prescribing disease-modifying therapies for Alzheimer's disease kind of requires an individualized or precision-based medicine and in a healthcare system where so many patients can't even get basic care. And so it's also, so how much is this costing patients? We know that Medicare covers 80%, and but then this is complicated by private insurers who were slow to adopt this as well. And so I don't have any data on how much people are actually paying, because this is still incredibly unclear and highly variable, dependent on insurance companies, but we plan to try to collect this data soon. And so a lot of unanswered questions, and Dr. Morris covered some of these, but so how long will patients need to be treated? No one knows yet. And so in the clinical trials, yes, they ran for 18 months, and the data that this drug was approved from is from those 18 months, but then most of those patients went on to be in the open label extension. So a lot of those patients are still on the drug with a treatment duration of 4 years. And so also, how do we assess treatment response? We need more objective measures in the trials. But right now in the clinic, we are using the same measures that we used in the trials, but these methods this is no longer a placebo-controlled trial, and so a lot of these measures aren't as effective as we need them to be, so we really need some objective tests, and possibly blood-based biomarkers, or there's consideration of PET scans to monitor, but we don't know if a PET scan if amyloid burden on a PET scan truly means clinical efficacy. So that's all these things that we need to figure out. And so there's also a subcutaneous formulation that's being studied in a sub-study of the original trial, and we're hoping that will be available in the future because that will decrease burden. And then the hot question of the week is, can a patient switch to a different anti-amyloid therapy with donanemab likely to be approved soon? And so we have to figure that out soon. And so, thank you.
Great, thanks, Madeline. And I think Madeline's being a little modest. Our center is providing access to lecanemab to more patients than any other academic center. So these numbers are huge compared to lots of other centers, and Madeline has been a big part of why we're able to do this. And while there are certainly side effects, at the end of the day, most of the people tolerate it quite well. So it's actually very encouraging to see this. Of course, we want to make things better, but it's impressive how much we've gotten done. So my name is Suzanne Schindler, and I'm the leader of the Fluid Biomarker Core, and I'm going to talk about some of these new Alzheimer's disease blood tests that you may have heard about. So I realize that some of you are veterans of these breakfasts and probably can tell us a lot about biomarkers, but I like to start with a really basic introduction for folks who may not be quite as expert on understanding what biomarkers even are and what they're used for. The first point is that cognitive impairment and dementia can have many different causes. So you can have cognitive impairment that's severe enough that it impairs your function and everyday activities, not just because of Alzheimer's disease, but because of all sorts of other reasons. Maybe you've had strokes, maybe you're taking a bunch of medications that are making you groggy. Maybe you have severe sleep apnea. So when we see a patient in clinic, we know they have cognitive impairment. We don't know why. And it turns out often there's multiple reasons. So it's important to differentiate cognitive impairment and dementia from Alzheimer's disease. So Alzheimer's disease is a specific brain disease, and it's defined not by the symptoms, but by this pathology, these amyloid plaques and tau tangles in the brain. Now, Alzheimer's disease turns out to be by far the most common cause of dementia, but as I mentioned, there's lots of other causes too. So what are biomarkers? Biomarkers tell you whether these amyloid plaques and tau tangles are in the brain. And if you do this kind of testing in a patient, it's very helpful. If it's positive, it tells you, yes, they have this in their brain, and this is a potential cause or contributor to their cognitive symptoms. If the test is negative, it tells you, no, they don't have Alzheimer's disease. Look at something else. Look for other causes. So these biomarkers can be quite helpful as we're thinking about what is causing my patient's cognitive symptoms and what do I do about it. And now, as Madeline was alluding to, these biomarkers are particularly important because the new drug that's available, lecanemab, decreases amyloid levels. So if you don't have high amyloid levels, the drug will do nothing. And so we have to do this biomarker testing to see if people have high abnormal levels of amyloid before we can even consider them for these new treatments. So as you all have likely experienced by now, we have multiple ways to test for Alzheimer's disease pathology. We do amyloid PET scanning. So this is when you're injected with a tracer. It binds to amyloid in your brain if it's there. And then we take a picture with PET, and it lights up if the amyloid's there. If it's not there, it doesn't light up, and you see a different pattern on the scan. Many of you have also gotten to experience the CSF collection, spinal tap. Thank you for doing this. This is still very important. This allows us to measure levels of different proteins in the cerebral spinal fluid, and the pattern is altered when people have the amyloid plaques and tau tangles. And increasingly, we're looking at other proteins in this fluid as well. And this really provides us with a gold standard for fluid biomarkers that we can then use to develop further into blood tests for Alzheimer's disease. And just to give you a few highlights from the Knight ADRC fluid biomarker core, we have really led the world in fluid biomarkers at the Knight ADRC. One thing that we found, and this was led by Dr. Morris, was that there are racial differences in levels of fluid biomarkers. We're still trying to understand why, but this turns out to be really important because all the CSF tests that are out there, and even amyloid PET scans, are really based on the levels and cutoffs that have been established in white individuals. And the levels that are associated with pathology in black individuals may be different, especially for certain tests. And it's important to know that because if you don't know that, you will end up misdiagnosing a lot of people who aren't white. So, and when Dr. Morris brought attention to this problem in 2019, this was not even on the radar. And now we're trying to validate these tests in many different groups to make sure that we're not disproportionately misdiagnosing certain groups. As you may have heard about, we also use samples from you guys to develop the first clinically available test for Alzheimer's disease called Procivity AD2. That was a first generation test and became clinically available in December 2019. And now, this past year, a second generation test became clinically available called Procivity AD2. It uses a specific ratio of phosphorylated tau, as well as A beta 42 to 40, to predict whether someone has amyloid pathology in their brain or not. And this test is extremely accurate. In fact, we think that depending on how you use it, it may actually be more accurate than the current tests that are used in practice that are FDA approved. And of course, the company that makes PrecivityAD2 is trying to get FDA approval, and I'm sure they will at some point. But in the meantime, we're still able to use this in clinical practice, and I'll show you some of the data for that. Something else that you may be hearing about more in the next year is there's this new analyte called, it has kind of not a difficult name, MTBR tau 243. It's a specific type of tau that seems to really closely mirror the tau pathology in the brain. And this is important because it corresponds much better with symptoms. So the tests that we have right now tell us very well whether you have amyloid plaques and tau tangles in your brain, not necessarily how much or whether that pathology is contributing to symptoms. This analyte, MTBR 243, is much better for doing that. So when we have this test, we'll be able to not only say you have this pathology, but this pathology is very likely causing your symptoms of cognitive impairment. We published a paper on this using CSF last year, and we're currently working on validating this in plasma. I think this is going to be one important advancement that will occur over the next year. Now, these blood tests are already changing patient care here at WashU. So we've been using these tests now for 3 years. We were an early adopter, but I think that our using them has encouraged other people to start using them. And as I'm talking to dementia specialists across the country, I'm hearing more and more about them using these blood tests as part of their clinical workup. So the first generation test was this PrecivityAD. It was good, but not as accurate as CSF tests. And we primarily used it to help us in cases where, we thought there could be several things going on to kind of prioritize. Oh, well, I thought it was Alzheimer's, but I did the test and it was negative, so it's probably not Alzheimer's disease. So it helped us as we were thinking about what was most likely to be the cause of symptoms. This new test is, as I mentioned, is highly accurate in telling us whether people have this pathology in their brain. And we are using this essentially to make the diagnosis that someone has this Alzheimer's disease pathology in their brain. And I think that it's accurate enough that we don't have to do a CSF or amyloid PET scan after we do this blood test. It's really that accurate. It's really rivaling the CSF tests. And this is really important because you all are very generous and have been willing to undergo these amyloid PET scans and CSF tests. Many people out in the community don't want to do those tests. These, having a spinal tap sounds scary to them, so they would just rather not get tested than get tested. And also, these are hard to access. So all of you come to the Knight ADRC for these tests. A lot of people don't live close to a medical center, so it's not something they want to do. It's not something they have access to. But blood tests are things that pretty much everybody can access. And so we think that these blood tests are really going to bring a earlier and more accurate diagnosis to many, many more patients, which is really exciting, not just in Missouri, not just in the United States, but all around the world. So we think that these blood tests will really transform the diagnosis of dementia globally, which is very exciting. And of course, this is important because these new treatments that we're talking about only help if you have this Alzheimer's disease pathology. And so the testing for this pathology is a major bottleneck in getting the treatments out. So many people will never, ever be treated or have access to these treatments without these blood tests. So we are really attacking this problem with our work here at the Knight ADRC. So in conclusion, accurate diagnosis of Alzheimer's disease requires biomarker testing, and it's even more important now that these new treatments for Alzheimer's disease are available. We have used these CSF biomarkers and amyloid PET scans in clinical or in research studies, like in you guys, but they do have drawbacks that limit their use in clinical care. And we think that because of the high acceptability, accessibility, and scalability of blood tests, that they're soon going to become the major modality for clinical AD biomarker testing. And you guys have really enabled this to happen. That doesn't mean that we don't want to keep doing amyloid PET scans or CSF tests. We want to make these tests better and better and better. And so we need those kind of reference standards to help us make the blood tests better. But you guys have well, by providing all of your samples and being willing to do all of this research with us, you have really helped us lead the world in developing these blood tests and that are going to provide access to all these new AD-specific treatments. So thank you for all of your contributions.
I wanted to thank all of you for coming today to listen to these excellent talks, and thank you to Dr. Morris for inviting me to speak to you today about obesity and elevated Alzheimer's disease risk. My name is Dr. Cyrus Raji. This is my first participants meeting. I've been on the faculty for a few years, and I helped Dr. Benzinger with the imaging core at the Knight ADRC. And as Dr. Morris spoke earlier to you, it's better to prevent Alzheimer's disease than to actually treat it once it has occurred. And one of the ways we can understand preventing Alzheimer's disease is by optimizing something else Dr. Morris referred to, which is brain health. And brain health has an academic definition. It is not just the absence of disease, but rather the presence of different types of well-being, whether it's structural, emotional, mental well-being. And this goes nicely in this Lancet paper with the WHO definition of health. So again, not just trying to eliminate disease, but promoting aspects that we understand as being wellness. And the reason we're interested in understanding obesity as a risk factor for Alzheimer's disease is because it's a lot more common now. To give you some perspective, in 1960, the number of individuals that were either overweight or obese by body mass index, which I'll talk about in a little bit, was 1 out of 10. In 2024, it's close to 7 out of 10. So just in your lifetime, you can see how there's been a change. And in this study published in JAMA a few years ago, what they found was that up to 40% of Alzheimer's disease and related dementias are related to some modifiable risk factors we can change. And in this study of almost 300,000 individuals, what they found was that of the 8 modifiable risk factors, obesity at midlife in the 40s and 50s was the most common risk factor for Alzheimer's and related dementias. But how do we define obesity? And this is a changing concept. You might be familiar with the concept of body mass index, and in this cartoon from the CDC, we have different numbers of body mass index, and so under 18.5 is underweight, normal is 18.5 to 24.9, overweight is 25 to almost 30, and then obese is 30 and higher. But what is the actual computation of BMI? It's essentially a mathematical function of your weight as a function of your height. But the problem with this definition is it doesn't accurately capture how much fat an individual has in their body specifically, because it looks at your bone mass, your organ mass, the size of your brains goes into how much your BMI goes into. It's everything that you have in terms of this information. And so it's not a very specific number. Even when BMI does capture fat, the type of fat it captures in 9 out of 10 cases is fat under the skin, fat that we can see. But what I'll also show you is that the more dangerous type of fat, visceral fat, is actually fat that is invisible to body mass index. And so according to the American Medical Association, body mass index by itself isn't an accurate measure of looking at fat. And so we need newer, more rigorous methods to understand how much fat an individual has, and do they have the worser type of fat that we're becoming to recognize. And the way we do that is with imaging. Now, everybody in this audience, they're pros at looking at brain scans and PET scans, but you're looking at a different type of scan here. And these are kind of top-down, kind of loaf of bread slices that we're seeing with different colors around them. These are scans of the abdomen, of the belly. And the reason it's important to understand this scan is that this highlights different ways in which my lab measures fat in the belly. And so what you're seeing here outlined in red is visceral fat. This is fat around the organs. And visceral fat is the bad type of fat. It's the fat most tightly linked to pre-diabetic, diabetic states, adverse vascular outcomes. And this is different than the fat that you're seeing here outlined in yellow, which is subcutaneous fat. This is fat under the skin that is actually not as tightly linked to diabetes. And so, put another way, it's possible to have a high BMI, but to have almost none of the bad fat and a lot of the not so bad fat. And so by measuring these specific types of fat, we actually have a better idea of understanding how this influences the risk for disease overall, but also the risk for Alzheimer's disease. And what we found in my laboratory is that visceral fat, that bad type of fat around the organs, is actually correlated to a higher amount of amyloid, the same target point that Madeline talked about in terms of all these infusion treatments. Visceral fat is actually related to amyloid plaque development in the brains of midlife individuals, people in their 40s and 50s, 15 to 20 years before they'll actually develop any symptoms of Alzheimer's disease. And the area of the brain that the visceral fat is related to in terms of the amyloid is in a part of the brain you're seeing here in red called the precuneus, one of the earliest sites of Alzheimer's pathology in the brain. And so the importance of this work is not just showing that obesity is linked to Alzheimer's disease, but that visceral fat in particular is related to the specific protein of Alzheimer's in the earliest area that we see it in the brains of people who haven't yet developed disease. So this preclinical phase that Dr. Morris talked about, this 20-year window of intervention and prevention that we can look for, we've linked this with visceral obesity in this study for the first time. But what Dr. Morris also talked about is that inflammation, the reaction of the body to the amyloid plaques that unfortunately targets the cells, the innocent bystander neurons, is also something that's important to understand in terms of the pathology of Alzheimer's disease. And obesity, specifically visceral obesity, is a pro-inflammatory state, which is to say it is linked to higher inflammation in the body as well as in the brain. And we see this on this image here of the brain. And so this is an axial view of the brain, and you're seeing green and yellow colors. And the green and yellow colors are located in the white matter of the brain, which is like your brain's telecommunications network. And all the yellow you're seeing here are parts of the brain that have higher amounts of brain inflammation in the white matter linked to a higher amount of visceral fat, that bad hidden fat around the organs. And this is in 54 individuals in our study, again, on average about 50 years of age, not having any dementia, not having any symptoms, and yet showing this elevated inflammation in the brain, as well as I showed you earlier, the amyloid in the brain as well. And so this really goes in line with what we understand as the molecular pathology of the disease. So what can we do about this? And I think this is something that's been very difficult for us to understand, because 95% of individuals that try to lose weight just through willpower alone have a lot of difficulty in doing so. But just in the last several years, we've seen the development of these anti-obesity, these weight loss drugs that are also used to treat diabetes, and you might know them by popular names such as Ozempic or Wegovy, and the generic name is semaglutide. But what we're understanding is that these drugs are not only very successful at promoting weight loss, but they may also have therapeutic benefits for lowering inflammation in the body and in the brain, and potentially preventing Alzheimer's disease at midlife. And so right now what you're seeing here is a figure from two main studies happening called EVOKE and EVOKE Plus, which are looking at close to 2,000 individuals in each trial, trying to understand if oral semaglutide, so you can take it as a pill form, can actually reduce cognitive symptoms and blood biomarkers, such as what Dr. Schindler was talking about just now, from Alzheimer's disease and brain deterioration. And if this study is successful, what that means is at midlife, individuals who do have obesity, especially visceral obesity, could utilize these drugs not just to lose weight and optimize their metabolism, but also reduce their downstream risk of Alzheimer's disease, such that if they ever do get the disease, they would get it much later in life, and they'd be more likely to benefit from these other drug therapies that we're using in individuals who are actually diagnosed. And so just this one class of drugs have many potential benefits that we want to investigate. And so in the years to come, we're really looking forward to sharing those results with you from our colleagues and also understanding how that could work in our population of participants here. And so with that, I'd like to thank you and my lab for the excellent work and appreciate very much your time.
So, Dr. So Dr. Araya Osval is our postdoctoral fellow for the past year, and 2 days ago was on an 8-mile jog in Forest Park and wrenched his knee and cannot walk. So he's not going to be here, but he did record his presentation on caregiving challenges among underserved populations.
Thank you, Dr. Morris, and thank you everyone for your continued participation in the memory and aging studies to advance our understanding of Alzheimer's disease and related dementias. Today, I will briefly discuss or highlight dementia caregiving among underserved populations, but mainly focusing on African American communities. So my agenda for today, or my outline, is this, but I will, for the sake of time, I'll go straight to my main slide and discussion point. So to give you an overview, there are significant disparities in Alzheimer's disease and related dementia prevalence, with African American communities experiencing higher rates compared to other racial and ethnic groups due to many factors. But the burden of dementia caregiving is experienced by all, despite race or ethnicity, and experiences differ by racial and ethnic contexts. And studies have shown that it is more complex for African American caregivers due to systemic inequities and disparities. And I also want to highlight these in two important quotes in the context of dementia caregiving. The first one is, no two people with dementia and no two families are alike in their needs for care and support, because everyone has unique family dynamic and may experience different caregiving. And the second one is, maintaining or enhancing quality of life is the ultimate objective in the context of dementia caregiving. So why is it important to address dementia caregiving? Because as the aging population increases, the number of people living with dementia is projected to increase, impacting patients, families, and government resources. Currently, over 11 million Americans provide unpaid dementia care valued at nearly $350 billion to society. And nearly half of all caregivers who provide help to other older adults do so for someone with Alzheimer's disease and related dementias. And family dementia caregivers often provide more extensive assistance than caregivers of individuals with other conditions. And studies have also shown that racial and cultural beliefs influence the diagnosis and treatment of dementia in the United States. So let's look at the unique experiences and challenges of African American caregivers. Study by the National Institute of Health shown that African American individuals were less likely to be diagnosed with Alzheimer's disease and related dementias. And when they were diagnosed, they exhibited more risk factors, greater cognitive impairment, and more severe symptoms than their white counterparts. And when we come to African American caregivers, they have less access to support services and primary care and have more unmet needs for the person living with dementia. They also face additional stressors due to the systemic injustices, financial instability, and lack of access to culturally appropriate resources and support systems. And studies have also shown that African American caregivers reported being dismissed or ignored by their primary care physicians when seeking care, which contributes to caregiving burden. And finally, African American caregivers engage in more hours of intense caregiving and delegate more of their monthly income to caregiving than other racial groups. And as I conclude my talk, I wanted to briefly highlight these important steps to improve dementia caregiving among diverse populations. The first is to promote dementia knowledge and awareness through education, research, and service. And secondly, it is to provide culturally appropriate or culturally tailored resources to improve dementia outcomes or caregiving outcomes for caregivers and for persons living with dementia. And thirdly, it is to build trust with local communities to improve communication. And lastly, but not least, is to establish sustainable community engagement through long-term community investment and building or creating genuine relationship with local organizations and stakeholders. Thank you for your time and engagement.
The first is not a question, but I think it's very important. A gentleman here says his wife is a patient of Dr. Holtzman, the new director of the ADRC, and last August began the new infusion, the infusion of the new drug, newly approved drug, Leqembi, and getting the infusions at Memorial Hospital in Belleville, Illinois. She was their very first patient, but now they have 23. And Madeline, this is great to have such interest in and ability to treat patients with Alzheimer's, but is there a limit to the number of patients that can be treated at these infusion centers?
So probably yes, we are already running out of room at most of our infusion centers, and this is like an ongoing project to get more spots, but this will be a problem if we continue with infusion therapy rather than other formulations.
So,
Yeah.
so the infusion centers, of course, are not dedicated just to Leqembi. I mean, many cancer therapies are infusions, for example, and so there's a big demand for these infusion centers. That's what I was trying to say in my presentation. This is new territory for us. We are just beginning this, and more drugs are coming, so more patients are going to be asking for these drugs, and we have to increase our capacity to do it. I don't want to say this, so please, if I do, forget it. We think that we are providing service to people who need drug therapy for Alzheimer's disease. Sometimes the people who run infusion centers are interested in the bottom line. And they don't want to increase capacity until they're sure that we're going to provide them this. You didn't hear me say that, right? Okay. Okay, we'll move on. Dr. Raji, is visceral fat always associated with abdominal fat?
Visceral fat is a big driver of abdominal fat, but like I was saying earlier, BMI won't detect it. Maybe only in 1 out of 10 BMIs you'll see that, and so that's why the BMI alone is not sufficient. And that's why we're going to need imaging techniques to better understand that. So, raise your hand if you've heard of like DEXA scans in the room. Have you heard of that? Okay, DEXA scan will tell you your total body fat and your lean muscle mass, but it will still not tell you whether or not you have more visceral or subcutaneous fat. For that, you either need an MRI scan, which there's no radiation, or a CAT scan where there is radiation. And so those are the two main things. So you can imagine a future in which we'll be building body health assessments into our brain health assessments.
Thank you. A couple of questions about receiving the biomarker results that Dr. Schindler talked about. So, for example, will the Precivity's blood test be part of the Memory and Aging Project biomarker panel, like with the amyloid PET and brain MRI and so forth? It already is. Already is. We are already getting Persivity AD. And the next question was, when will patients receive testing results? So I'm going to do something I do this a lot. I'm going to ask our two investigators, Dr. Sarah Hartz and Dr. Jessica Mazurski, to pick up a microphone and address the question of when will patients receive testing results. Jessica or Sarah?
Hi, I'm Sarah Hartz. I think you heard, well, Jessica, did you talk earlier? I don't know. Jessica stood up earlier, at least. We have answers. We have brochures about the details of when and how we're planning on returning results if you haven't already received results and what our future plans are. A lot of it was in the presentation that Dr. Morris gave, but we'd be happy to answer any questions.
And I'll just also add that we are currently not actively recruiting. We're doing some return of results, and Sarah and I are going to spend the next 4 days locked in a room writing the next grant to allow the expansion that Dr. Morris was talking about. So there may be a slight delay at times.
I have made a commitment, by the way. I think returning research results to you, any of you who want it, is so important that even if Drs. Hartz and Mazurski find that their grant is not funded, I know that's impossible to imagine, but even if it's not, I will commit funds that I have available so that we can do this. So it may not be immediately, but we will get your results to you. I'm going to ask Dr. Schindler to address this one. Dr. Schindler? If someone is getting this lecanemab infusion now, at the conclusion of that, should they go on the new drug as well?
So lecanemab's the only drug that's really available right now. Donanemab, we expect may be approved, who knows, in the next couple of months. They actually do very similar things. So they both lower levels of amyloid, and they lower it to the point that it's essentially zero, so it's below the limit of positivity. I do not think there would be an advantage of switching from one to another, except I suppose there could be rare cases, but no. The basic answer is we would not treat you with lecanemab and then switch to donanemab. They do the same thing, unless Dr. Morris thinks otherwise.
It is interesting. I think this is an interesting therapeutic question. I said it's a new era. We don't know. The lecanemab trial went for 18 months, and they said that removed amyloid from the brain, and it benefited patients because it slowed the rate at which dementia progressed. Didn't stop it, but it slowed the rate at which dementia progressed. The donanemab study did the same thing, got the same results, but the people who ran that trial said once the drug was effective in removing the amyloid from the brain, why give the drug anymore? The purpose of the drug is to get amyloid out of the brain. It does that, so why keep giving it? We don't know what to do. So this is something we have to figure out. Cyrus, what about the PET scans and the MRI scans? Do they show fat in the brain?
Yeah, actually, this is something that we're looking into right now, where you can look at fat in the neck as well as fat in the scalp to see if that could be a secondary marker of fat elsewhere in the body. And right now we're looking to see if we can validate that to the data that we already have, so that when you're getting your regular brain scans, you may have some secondary clues about what the fat burden is elsewhere. What we don't know is if the scalp fat or the neck fat is more tightly linked to the visceral fat, that hidden fat that's really bad, or the subcutaneous fat that's more common. And so that's what we're investigating now.
Here's a question on whether stress and mental health can increase one's risk of developing Alzheimer's disease, and are we examining that? another member of our staff who I would call on to address that is studying that very question. Unfortunately, she can't be here because of a problem with her in her family this morning. But we are very much looking at chronic stress, and we think it's deleterious to brain health and may be a risk factor for Alzheimer's disease. And it's one of the issues that we are particularly concerned in certain of our marginalized groups who face really lifelong discrimination, lifelong stress, and may be a factor in why certain groups are more prone to developing Alzheimer's disease than other groups. Okay, Cyrus, you are very popular today. Tell us a little bit more about these weight loss drugs and how they might affect Alzheimer's. Do you think they could benefit Alzheimer's disease?
Thank you, Dr. Morse. Yeah, I think just beginner's luck today. But these drugs operate on looking at insulin pathways. And the reason that's important is because insulin in the body, when there's too much of it, especially in early diabetes and diabetes, it actually inhibits the same enzymatic proteins that break down amyloid in the brain. So it can promote accumulation of amyloid in the brain, but at the same time, inflammation from abdominal fat and diabetes can also reduce the brain's clearance system. We call it the lymphatic system, but it can essentially clog up the pipes. And so the idea is that these drugs like semaglutide can have multiple mechanisms of action to reduce inflammation and these downstream effects, which is why if we can make them work at midlife, it'll reduce this risk of damage later on, because as Dr. Morris was explaining, this takes decades to develop in terms of the pathology. So earlier treatment targets will be more effective.
Thank you. Dr. Schindler, is there a correlation between sleep and Alzheimer's disease?
Yes. and actually, WashU has published some of the initial reports discussing this connection, and there are much better people than me to answer the question. But yes, basically, it's interesting. Poor sleep seems to increase your risk for Alzheimer's disease, and Alzheimer's disease seems to increase your risk for poor sleep. So it's a bi-directional relationship. And probably those of you who are caregivers are experiencing or have seen how Alzheimer's disease can affect sleep patterns, but also poor sleep can increase risk. So it's very complex interactions that we're continuing to study.
We have several studies about the relationship between sleep and Alzheimer's disease. So the good news is, so far, the more sleep you get, the less risk of Alzheimer's. And that sounds good, doesn't it? Madeline, what are some of the challenges that our clinic has found in getting insurance companies to cover the cost of treatment of these lecanemab?
I could talk about this for hours, but so initially it was a little worse. Everything was being denied by the secondary insurers, and so MRIs, not all the tests, but many of the tests to first diagnose Alzheimer's, so the PET scans, but with help from people like Dr. Schindler and others, it's gotten better, but Dr. Schindler can agree that we've been fighting with insurance companies more than probably we ever have, I guess, and so it's very dependent on which insurance company, and it's been a challenge for them too. So we have to give them that this is a change for them too, and they have to adapt their policies to accommodate this drug. So I'm not going to bash on them too much, but
some insurance companies have readily paid for this. Medicare now pays for an amyloid PET scan, or at least reimburses, 80%, something like that. They didn't used to pay anything for it, so now they'll do that. And some insurance companies pay for the treatment. Some companies say, we're not paying for it. We don't understand this, because Medicare is paying for it, so, or reimbursing it. So very interesting. A question here about nanoplastics or microplastics in the brain. We are not studying that, but our biostatistics coordinator, Kenji Zhang, is studying, and I just mentioned it very briefly, the fact of pollutants, and particularly particulate matter in the air. And so he's done a small pilot study. He's putting in an application to do a much larger study wherein individuals who participate wear a small device that measures the amount of air pollutants. And it is already beginning to show that the pollutants do seem to increase risk for Alzheimer's disease. It's a new era of studying a new risk factor, but the idea of pollutants as risk factor for anything that damages the brain is a very viable area of research. Do you know that the home, and particularly the kitchen, is probably the largest risk of air pollutants, the stoves in particular? I didn't know that, so I now get carry-out, so. Dr. Schindler and myself were asked just, I don't know, past week or two to talk about a new report led by a person named Dean Ornish. Does anyone know Dean Ornish? And he published a paper in a journal saying that people who adhered to his program, which includes a very restrictive diet, very big on vegetarian, vegan, and exercise program, may reduce the risk of Alzheimer's disease. So lots of interest in this. Suzanne, you want to comment about it?
Yeah, so my primary concern about it is it's a very small study, so I would consider it to be kind of a pilot study. So it's a sort of thing that would be a great jumping off place for further studies, but in and of itself it was not very definitive. And it actually didn't follow people for very long. We always recommend diet and exercise to all of our patients. So we're already doing this to some extent. In this study, they provided a lot of support in terms of meals and all sorts of coaching to make sure that patients or the participants actually did it. Again, it was very small. I think it was like 51 individuals. They did see positive effects, which is great. My concern is more, can they sustain that over time and continue that? Just because some of these interventions, you know, a lot of us will exercise for a month or two and then we'll kind of give it up. So a question is this really sustainable over the long term? Maybe it is, maybe it's not. I do think that all of these things are important. It's just, I don't think, for example, this is going to be the cure for everyone. They also started out with I think around 1,800 people that they looked at for the study, and they only included 50. So maybe those 50 are very special and different than the rest of the population. They found some interesting results with plasma biomarkers, but it was quite difficult to interpret for a number of reasons. So overall, you know, it's interesting, but I just would caution people about over-interpreting the results.
And I don't know Dean Ornish, but in general, I'm not saying this applies to this study, but in general, I'm a little dubious of a report that says, if you take my program and pay for it, you'll get better. Question here, Suzanne, about is the Procivity AD test available? Can anyone get it?
So yes, it is available, and we offer it to patients in our clinic after consideration of lots of other factors. In some cases, a CSF test may be more appropriate, or an amyloid PET scan. So it's very selective who we do it for. We do not offer it to patients who are not cognitively impaired. So that's a question we often get. If I'm just worried about my risk, can I get it? The answer is no. And actually, C2N, the company that offers it, makes us attest to the fact that the patient has symptoms. And this is important for a lot of different reasons. At least clinically, if people find out they're positive, at this point there's not necessarily anything they might do about it. Maybe they would increase their lifestyle interventions, but maybe not. However, you guys are research participants, and almost all of you have probably had this. So if you are interested in your results, I would talk to Sarah and Jessica, and they can provide you with all the information you need to know whether this is something that you really want to know or not.
Yes, and Dr. Hartz and Dr. Mazurski have all of your results. They brought them with them here today, so just see them after, and they'll give you. Cyrus, so is there an age effect for these weight loss drugs, the semaglutides? Is the effect on weight loss in young to middle-aged people different than from older individuals?
That's a very great question. I think one of the concerns
Thank
about...
you, that's why I asked it.
Well, so actually, it was at the ADRC, and Dr. Morris, of course, co-authored this paper showing that as people have obesity in late life, it's actually protective, because the idea is that as people are losing weight, it could be an early marker of the disease, and so activities of daily living, self-care, it could actually be impaired. And so the strongest literature suggesting that obesity increases risk for Alzheimer's disease is at midlife, in the 40s and 50s. It could be in younger ages, but we know it most definitively for midlife. And so the effects of a lot of these weight loss drugs are being best understood in that age group, although the EVOKE trial that I told you about is being studied in 55 to 85-year-olds. So we will have the answer about how it applies to the age groups that are going to be having a lot of big interest. But one of the reasons I think why the literature is so confusing for late life obesity is because those studies just use BMI, which don't tell you about the different types of fat. And so as we refine our understanding in late life, hopefully, we can have better answers to these questions, and I think better applications of these treatments.
Great. Here's a question. Is there a difference in the risk of Alzheimer's disease in people who are living in Africa versus African Americans? And the answer is yes. A very interesting study started in the 1990s, many years ago now, evaluated the risk of developing Alzheimer's disease in the Yoruba tribe people living in Nigeria. And they were in a town, Ibadan. And they compared it to the risk of developing Alzheimer's disease for African Americans living in Indianapolis. Both groups of individuals did develop Alzheimer's disease as they got older. Age still is the #1 risk factor for Alzheimer's. The older you get, the more at risk you are for Alzheimer's, and that happened in both the Yoruba in Nigeria and the African Americans in Indianapolis. But the African Americans had a much higher rate. So very important. It probably isn't African ancestry that's the risk. It's our lifestyle, or Yoruba don't undergo discrimination. We're talking about stress, right? Lifelong stress. Well, I mean, there's a lot of food for thought in that. But it's not African ancestry, it's seemingly, that puts you at risk for increased risk for Alzheimer's disease. Dr. Schindler, why does it take so long for the FDA to approve these drugs?
Well, the goal of clinical trials is to make sure that drugs are safe and effective. And it takes a long time to figure that out. A lot of these trials, the ones that we're talking about for donanemab and for lecanemab took 1.5 years. But it takes time to recruit people and to follow them. And actually for these trials, they follow them after the trial is complete. And then so it takes us several years to do the trial, and then the FDA reviews it, and sometimes that can take a year. But I think you heard about some of the concerns, some of the side effects of the treatments. I think that if this were just like a pill that everybody took and there were no side effects and everybody was cured, that would be one thing. But I think there's some complexities to this treatment, and so the FDA's really had a pretty high level of thought about these. But after reviewing all the data, they think that for some people that the risks or that the benefits outweigh the risks.
Here's a question about why more and better education might decrease risk for Alzheimer's. So there's a concept called brain reserve. In essence, you can think about a brain that is either bigger or somehow better and can withstand diseases without causing symptoms. And education is a factor in brain reserve. The more and the better the education, the more brain reserve has. In another term that people use, maybe the brain is more resilient and can withstand the Alzheimer pathology without causing dementia. Interestingly, in people with high education, it is true that they seem to go longer, even if they have that preclinical Alzheimer's disease, without getting dementia compared to people with lower dementia. People with lower dementia get the dementia much earlier. But once the people with high education, if they do get dementia, boy, they go right down the hill. So it sounds like they were stable for a period of time, but when they were finally overcome, they really, really showed it. Okay. Again, I'm going to turn to Dr. Mazurski and Dr. Hartz, because this is a very important question. What are the advantages or disadvantages of getting your knowledge, whether you have a positive or negative Alzheimer test? Yeah, sure.
Okay, so hi everyone. Can you hear me okay? Okay, so it depends, I guess I would think of it as two groups. For people who are currently have no memory and thinking problems, the benefits are that many of you have told us, I want to know because it's about me. I'm curious. I might use the information to plan. And I just have a right to know, right? The risks can be that for some people, if you get a result that suggests you have an increased risk, you might feel really upset and worried and psychologically anxious. That's what our study is monitoring, right? Worry, anxiety. It's possible your insurer or employer could use that information, if it made it into your record, to discriminate against you. So we spend a lot of time telling you about those types of risks. And another thing we're interested in, and we don't yet have the data, is if you learn that you're at higher risk and you come back every year for your memory test, do you start to do worse on your tests because you actually think your memory is worse? Or every time you forget your keys, you go, oh, I knew it because I have elevated amyloid. So that's one, right? And we're monitoring all of that. We really are. But for people who have mild symptoms, there are some benefits to knowing because it can help confirm or suggest something else is going on. So it can confirm a diagnosis, suggest something else is going on, and now it could help you get access to a treatment. So what we're hoping going forward is to increase who can access their results and think about how to get it in the clinical record. But as Dr. Morris said, we haven't seen any of psychological harms, which was a big worry. So most people who want it have not been overly anxious or worried afterwards.
Thank you, Jessica. All right. By the way, congratulations to all of you. You are so interested, so perceptive, have such good questions. We obviously can't get through them all. We save these, and we try to address them in some of our newsletters and things of that sort. But I have a few more questions. Madeline, we were talking a lot about Leqembi and maybe donanemab. Is Aricept still a good treatment for Alzheimer's disease?
So most of our patients are on both, and so that's a symptomatic medication for Alzheimer's disease that's been around for, I think Dr. Morris said, almost 30 years, 1996, I think.
Yep.
And so these work on two different ends of the disease. So we still recommend trying it, but we don't necessarily say that it's the standard of care. But I'll let Dr. Morris answer that.
Well, I think the idea, at least for the trials, we haven't done this in the clinic, but it's pretty hard to evaluate whether people get benefit or get side effects when we start a treatment if we start two treatments at once. So we like, if people are going to be on Aricept, and most are, like Madeline said, we'd like you to be on it in a stable dose before we add the new drug. Does that make sense? Okay. Dr. Schindler, I'm concerned, I'm hesitant to undergo the lumbar puncture. What are the downsides of this test?
So we obviously do CSF tests on many of the participants. So I would suggest you chat with some of the folks at your table about their experiences. We also offer this to our patients, and so I have done quite a number of LPs on my patients in particular, and they're often nervous about it. And I think the biggest reason is they've never had one before, and so it's a fear of the unknown. And after the procedure is complete, the most common comment I hear is, "That was it?" So I think that people may kind of work their way up, or get nervous about this, especially kind of the period between when it's scheduled and when it's happened. But most people tolerate it just fine. And if you, if I took you through the procedure, it's in many ways not that different than getting your blood drawn in terms of there's like a needle involved and a small needle. We actually use numbing medication for it, so I think it probably hurts less than getting your blood drawn for a lot of people. So in terms of specific risks, so I think the biggest one is that sometimes people have a sore back afterwards. Sometimes people have a headache. And the headache usually goes away, but in a very small percentage of people, maybe 3%, the headache is persistent, and then we do a second procedure called a blood patch, which fixes it 99% of the time. Again, most people tolerate this very well, though. So, and I would encourage you to talk to folks around here about their experiences.
So I would say it, any test, like any drug has side effects, any test you could get a side effect. But done correctly, and we only do it correctly, I'm serious, a spinal tap is no more problematic than a blood draw. The problem is, in my mind, is it's done in your back. You don't know what's going on back there. That's why, I think that's why people are afraid. Okay.
I wrote on my card, taking the blood test saved my life. This happened last fall, I guess it was, and a few weeks later I got a report, and it had 6 results of the 6 different things I guess they analyzed the blood for, and 4 of them, and it said whether the results then were within the normal range. 2 of them were not in the normal range. So I made a copy and sent that to my primary care physician. He called me, set up an appointment and said, I want you to go see a cardiologist. And they did some more testing and ultimately found like a 90% blockage in one of my arteries and put in a stent. And so in my mind, This blood test helped me prevent a heart attack, where then they treat you with, putting you in the emergency room and giving you a stent. Instead, it was no muss, no fuss. Take some tests, and they did it ahead of time. So thank you very much.
I'm so glad that you got the test, and that's great.
So we are almost out of time. I'm going to answer one more question. Why does Alzheimer's disease cause death? And the reason is because the end stage of Alzheimer's destroys almost all brain function, and people no longer can swallow. That's a brain function. And they either can't take nutrition or hydration, or if they do, it doesn't go down the right pipe, the esophagus, but instead goes into the lung and causes pneumonia. It also affects mobility. People fall, break bones, or end up not walking, get bed sores. So they die of a general deterioration of the brain and its function. You'll hear that Alzheimer's disease is the 4th or 5th or 6th leading cause of death in the United States. I think it's the 2nd or 3rd, because when people with Alzheimer's die and they have that pneumonia, what goes on the death certificate? Pneumonia. They got pneumonia because they have Alzheimer's. All right, last question. Let's see. So if your grandchildren will eventually fill your spot, does that mean you'll stay on until then? You all were terrific. Our 4 panelists, Araya's not here, but our 4 panelists were terrific. One more time, let's give them and you applause.